on the Google Meet, which I got rid of now, but I went on there and told him to switch over to this, and he hasn't come over here yet. So that's why he's not here yet.
Who's that?
Steve had gone on to the Google Meet because it had popped back on the invite as a Google Meet still.
Yeah.
And I went on there and told him to switch over to this one, but I don't know if he understood. I got rid of the Google Meet though, so it should have kicked him off of it, but
Yeah, it automatically makes that option when you're scheduling it through the Google calendar. And I've had to catch it a couple times trying to sneak it in there because it just confuses people.
mm-hmm.
Well, folks, I have 10:30. I'll call the meeting to order. The neighbors. Roll call. I see that we are missing Supervisor Jensen. Otherwise, all are here, along with Chair Bartlett. I'm sure we all had a chance to read the minutes. Is there a motion to accept the minutes?
I would have moved to accept as presented.
Do we have a second?
I'll second.
Kelly moved and Sarah second. Any other discussion? In hearing none, all those in favor say aye.
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 Opposed? Carried. Is there any public comment? Anyone know? Ken or Carmen?
Ken, do we have anybody?
I'm not seeing anything right offhand, but I'm trying to, I'm not seeing anything.
Okay, thank you. So we'll go to item 5 on the agenda. Considerations to be taken by the committee for action, review of the vouchers. Does anyone have any questions on the vouchers? I went through them. They're as long as ever, so. Nobody has any questions, and we'll jump right into Jane's financial report.
Okay, thank you for having me early. I need to skedaddle after this. So going right on into it, we have the campus census, which I prepared the chart. Medicaid seems to be okay. The private pay is lower, and of note is the Medicare A days, which drives some of our acuity as well. So when we look at Medicaid rates and what goes into that, it's that Medicare A acuity that really helps us out as well. So 6 months from now, that might be a factor in rate setting. So that's the census. Any questions there? Okay. Aging report is looking stable. We have a couple big things that went over into the over 365 days bucket that we're monitoring. And with a lower census, we have, a lower amount going into the current and the 31 to 60 day bucket as well. But it seems to be managed. We have lost one of our good billers, and hopefully that won't impact us too much because we seem to be caught up. And we have a temp working as well now, so that should flow and keep our aging stable. Any questions on the aging? Okay. And pool staff. We didn't have a lot posted in August because we had an early meeting and we closed the books a little bit earlier. So in September, the amounts of those invoices did post, and so it will even out between the months. It's not as high as last year. Of course, we're not using as much pool staff because it's not available and COVID. So questions on the pool staff amounts? No, quiet bunch today.
Well, we know you're in a hurry, Jane.
Oh, I'm not in that much of a hurry. My plane doesn't leave until like 4 o'clock. So I just have to, my transportation needs to leave at 11:30. So, and then the income statement. I have the first page up on my screen. The census, of course, is what it is. It's lower than we want. The revenues are 9,900,000 versus the 10 million budgeted. So we're below in revenues by $500,000. And that includes that COVID reimbursement. So we're actually, like $1 million, at least $1 million off on revenues, which is substantial. Expenses look like they're holding their own. The only places that we're over is, of course, with the medical records and purchasing, which is all that salary COVID. Those are pretty close. I'm not concerned about that. Everything else seems to be good. We have a little bit lower expenses in administration that I'm looking into. SAP continues to be a challenge of posting things. So we'll get an update on that next month. But overall, I think it looks healthy with the COVID money posting and being applied. We're holding our own and don't expect to be on tax levy this year for operational items.
Good.
Questions? I have till 11:30. Just kidding. Okay, that's the report. I continue to work on the COVID provider relief funding, and there's one more round of COVID funding, phase 4, that we just applied for. It's unknown if we'll get anything or if we'll get a lot. It was a struggle to apply for this one. It was more than just pushing a button. So we did a lot of research and put in revenues, expenses, and we'll see what we get maybe next month or the month after, but there may be more money coming.
Good.
Yep. And Medicaid rates, Carmen, are you going to talk about that later or you want me to do that now?
We can talk about it now. I was actually just gonna throw that in there right now, so.
Okay, yeah, we have projections from our leading age contact who used to be a Medicaid auditor. So he's pretty well versed in what's really happening in Madison. And he ran the reports for all the facilities. His projections show between our 3 buildings, was an 11 and 13 and a 12% increase in rates. We budgeted for 10, so that's great. And our Medicaid census is higher, so that will help us more because we've got more Medicaid people. I've talked to a couple other facilities. One got a 2% raise and they're not quite sure why. So I'm really happy with Rebecca and Stephanie, the MDS people that have charted our acuity. Those increases are based on our charting of acuity, isolation, COVID, people who have rehab of all sorts, and hats off to them for keeping our rates high.
Good. Are there any other questions for Jane?
Mr. Chair,
Yes, Dave.
not a question, but I'm wondering if Ken could try calling Steve. He hasn't gotten onto this meeting, and maybe help him get on it. If he was going to come to the meeting on the Google Meet, he evidently is there trying probably to get on. So
I'll try to reach out to him.
thank you.
Okay.
Okay, a question for Jane. When do these increase in Medicaid rates take place? And when will we actually see them?
Great question. They will go back to July 1st, 2021. Our last rate letter was for April. They came out quarterly. So we'll be getting back pay for those when they process those, hopefully by the end of the year. They're thinking November, and they will be in place, these rates, until the next cycle starting next July. And Carmen, correct me if I'm wrong, I don't think we get quarterly updates anymore then, right?
No.
Because
Yeah, go ahead.
they're changing, besides giving us the big bump in their reconfiguration of the financial piece based on, a multitude of factors. They're also changing how we bill We used to have a flat rate. You know, the Medicaid rate is this much per day for everybody. They're going to a whole different model. The model is called the Pdpm model, which is the same as Medicare and is based on their acuity, their nursing, their therapy, their medication use, their mental health, all the factors. So it's a more comprehensive scoring. And then I don't know how they're implementing it. That's still to be determined. They're testing it in December for implementation in January to see if their computers will all do it. But that's how important it is for our nurses to chart, and because of that new rate and acuity basis of payment.
So hopefully,
July.
yeah. So hopefully that'll be a positive for us, that it's going, because right now our rates are what is basically an average, but it's an average from the past. It's not an average of right now. So as people's acuity go up, then the next quarter at the time when it was quarterly would go up, but as their acuity, we wouldn't be being paid for the actual rate then. So this will hopefully be a little bit more real time and being paid for each individual instead of an average of the whole, especially if census is lower in a certain building. One low acuity person can really drag that down versus because it's just a lot of averages right now. So with this new model, we're getting actually paid for the services we're providing for those higher acuity people instead of the average. So hopefully it will be good for us because we do have quite a few high acuity Medicaid residents. So.
Good. Are there any other questions for Jane or Carmen on that subject or any other subject? Well, thank you, Jane.
Thank you.
You bet. Is there a motion? I'm seeking a motion to approve the vouchers and the financial reports. Anyone?
So moved, Mike.
Supervisor Kinnear moved. Is there a second?
Second.
Supervisor McCulloch, all those in favor? Oh, I'm sorry. Are there any other questions? And hearing none, all those in favor say aye.
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 Carried. Okay, Carmen, we'll jump into your administrator report, please.
Okay, as always, we start with the Quality Assurance Steering Committee updates. This month, we did look at our quality indicators or quality measures, which we do on a quarterly basis. They come out from CMS quarterly. So we did have that this month. It was interesting because we did see a couple of changes, primarily in the central building, which is to be expected. It's similar to those Medicaid rates. One outlier throws off the law of averages, and especially when we have a lower census, which we currently do in central, it's all about percentages. So one person that has a fall with major injury or one person that has a skin event could result in having above average metrics for percentages when you have less people in the building. So we did flag for a few more quality measures. What that means is they look at those when they come in for survey. Typically, the sample that they use for which residents they look specifically at survey is based on those. So they'll look at things that are off on quality measures and then they'll focus on those. With Central being our next survey, we do anticipate them focusing on all the things that we have flagged, which again is a little bit skewed since we have less residents, we have more things flagged. It's not necessarily that there's more events happening or more issues, it's just law of averages. But we did review all of them. We don't have any that we saw as being a major issue, which is good. So we did go over that in depth at the quality assurance meeting. We then went over our regular reports. This month's subcommittee report was the quality of life subcommittee. So as Alyssa, our new life enhancement mentor's first time reporting on that. So we did go over our quality of life and there wasn't any trends or issues with that as well. And then we did go over our normal QA committee reports with nothing specific to report on. Is there any questions about QA? The next item is probably our biggest discussion point. We put it before the employment activity report because a lot of these things come up as questions from the employment activity report. So we thought we'd talk about it in advance of that. So I'm sure you all, the committee members, received my memo that I sent out a week or two ago regarding the current staffing situation at the neighbors. So as you're all aware, we are having significant staffing issues, primarily for CNAs. We are having nursing and homemaker issues as well, but primarily CNAs is our biggest issue. It is something that we're well aware of, that we are trying actively to make changes and to combat the issue. So I have met with HR, which we'll go over a few other things in a little bit that came from those meetings, as well as trying to do a multitude of different avenues to help with the staffing shortages. One of which is the emergency staffing waiver. Basically, we can have people trained as CNAs without going to the actual CNA class. This is a COVID waiver program. It's basically they take a class that's 16 hours online, and then they have to be directly supervised while doing any tasks and be able to do the task and prove that before being on the floor by themselves. So we do have at least one homemaker and a couple others that have been learning to be CNAs to help out with that as well. As we've been doing for quite a while, any management staff that is able to help has been helping with whatever they're able to help with, including meals, if they're able to help with CNA or nursing care, and then dinner serving and laundry and dishes and things like that. We have also extended our agency contracts. So offering higher wages for the agency contracts, as that is what we have been told from them, that why we can't get agency CNAs is because other places are offering more. And we have also stopped admitting to the neighbors. That'll be also brought up in the census report later on in my report, but we have stopped admissions to the neighbors. We are today closing Fireside. We're having our last resident in Fireside discharge and one other resident move to Deerview. We are waiting for, we had 3 residents down in Fireside. We had 2 open beds in Deerview. So one was discharging home. So we are waiting for him to discharge home and then move the other 2 over to Deerview. If we're moving them from central to east or west, that is actually considered a discharge and then an admission, which we cannot do for staff convenience without issuing a 30-day notice. It is considered separate facilities in the eyes of the state, so it would be no different than us discharging to American Lutheran Home or Colfax. So we'd have to do a relocation plan. So this was our most efficient way to transition out of having Fireside open. Doing that will alleviate having a staff member down there on all 3 shifts. So that'll hopefully help staff the other households. Then if we are able to have fully staffed in the other households, which also are not at max capacity at this time, at that point would be when we'd evaluate admitting to those households, but currently we're not admitting to any household on campus. And our census is at 96. So we are much below our average and trying to keep it as minimal as possible to make sure that we're caring for the residents we do have with the staff we have available. At this time, we also have the information that from Heather and HR and Jenna. I don't know if Paul, if you wanted to share your screen, if you have that. So myself and Heather had met a couple of weeks ago and kind of brainstormed a few different ideas for retention and recruitment of staff for the neighbors, a few different ideas and changes we could make. And then subsequently to that meeting, Jenna from HR had done some costing and some planning on those ideas, and then met with both Keith, myself, and Paul And so we are going to go over some of those ideas, which from after this meeting they would actually go to the Committee on Admin, but could use an endorsement from the Neighbors Committee. So a couple of those ideas. The first one would be, we called it loan CNA pay. So this is an idea that was actually brought up by a CNA at the Neighbors. It would be that if they are working short, so typically on days and PMs, we staff to have 2 CNAs per household if the household is full. And that if they are working short or having 1 CNA per household, a question was brought up, would we be able to get incentive pay for doing extra work by working short? So the idea of this would be to give them the incentive pay that would be paid out to mandate an employee, which is $5 an hour pay. Instead of paying that, we would obviously, if we could, have that second person there, but since we're short-staffed at that time, not having that second person there to give the CNA that is there by themselves an extra incentive pay for doing extra duties by being alone, just to show that we do value them when they're able to work and sometimes in a short-staffed situation. So it would not be an additional cost on the budget, as the budgeted amount would be to have 2 staff there. So it would actually be less than what this paying of another employee would be for that shift. So that's the first agenda item, or first idea, I guess, not agenda item. The second one was one that was a little bit more costly. This one is a shift differential. One of our hardest shifts to fill are PMs and nights. Even though we do have shortages on day shift too, but PMs has been historically the hardest shift to fill. We currently do have a shift differential for our night shift of 40 cents an hour additional. This is something that was an idea driven partly by market. Our competitors do offer shift differentials. So we costed out 3 different options of a shift differential for $1 extra per hour, $2 extra per hour, and $3 extra per hour, with the cost of what it would be for the rest of this year, as well as the cost of what it would be for the entirety of 2022. The idea with this would be, it would be very difficult if we offered this for the end of the year, and then taking it away going forward would not really be a wise action on staff morale as well. So that is why Jenna costed it out for the rest of next year as well. The idea behind the dollar increments was to see the overall costs of the different options, but at the same time be competitive with what we're seeing in the market, which is between $2 and $2.50, that's what other places have been offering for shift differentials for their employees on PMs and or nights. This one is definitely more costly and would not be something that would be easily absorbed, but it was an option that was an idea we wanted to cost out. And I don't know if Paul, if you wanted to talk more there, if we should continue to the next one.
Yeah, I'll kick in just to support what Carmen has said. So yesterday, Carmen, Keith Stray, our CFO, Heather Murray, our HR director, and myself, along with Jenna Nutter, who did the work on this from HR, and Jenna did a very fine job, very useful information. We talked through these various options. So the shift differential is the most difficult of the options that were presented and costed. Our understanding is that it is something our competitors are able to offer at $2 to $2.50 extra in terms of incentive or compensation for working the PM shift. But again, to repeat what Carmen said, if we do this for the remainder of the year, it would be very difficult to take it away starting fiscal year 22 in January. So we cost it out for the remainder of the year. And those numbers are significant. $104,000 for the $1 an hour shift differential, $229, almost $230 for the $2, and over $350,000 in cost for the $3 an hour shift differential. And the difficulty is we don't have the funding. We don't have the source of money, the revenue projections to cover these costs. So implementing this would have to be funded by the general fund, the county's general fund. And I think most of the supervisors on the committee are aware of the strain that's put on the fund balance of the general fund. If we make doing this a priority, we risk not being able to fund other things. And we can't presume necessarily that this is the appropriate way to go. Given all of the priorities, the priority discussions across the entire gamut of services and programs. This is that typical give and take, that push and pull. So it was our consensus at the staff level that this one is the hardest pill to swallow, as much as we feel it may be important to address this critical issue of attracting and retaining staff. It may simply be, it looks like it is simply beyond our means at this time. So we put that out there for your consideration. And what I recommend, Carmen, go ahead, we'll talk about the other remaining two options and then ask the committee to weigh in on each of these.
Okay. Okay, so the third option is the vacation payout for NDC employees who reach their maximum. This is something that's actually been done across the county and other departments. We are just adding it in for this to go on longer for NDC. It's part of our overall county, but that would end at, I believe it's the end of the year is when that policy change or operational change ends. So this would just be to include it. So this is something that we're already doing. If an employee reaches their maximum vacation in SAP where it stops off their maximum allowed vacation, it typically would stop and then stop accruing. This would be, and that would be in the case that an employee would not be able to take vacation because of staffing shortages and just the inability to actually take the vacation past that point. And then that would be the payout for that, the accrued over the maximum amount. So that one is one that we're already doing. We just thought it'd be wise to include it in here since the staffing shortages and issues at the neighbors is unlikely to be resolved before the end of the year, trying to be proactive on this measure. Then the fourth option is one that I believe would have the biggest impact for the smallest amount of money, I guess, would be the applying of the 2022 proposed rates from the class comp study to NDC employees prior to the beginning of the year. We are still a couple months out from the beginning of the year. This is costed to October 15th, since it was the date range that we were in when Jenna was working on the costing for this. The October 17th would actually be the start of a pay period. So if we did do this, we would be proposing to have it start and backdated to the 17th. This costing is for all NDC employees. It is for $12,587 would be the amount of money it would cost to enact that proposed rate change early. It would not be that they would get the rate change now and then also the increase then. It would just be they would get the rate change early. And the costed out number of the $12,000 is costed at what we budgeted for staff. So we budgeted staff at max capacity, fully staffed, and we're obviously not at that point. So the actual dollar amount that it would cost to do this would be lower than that 12,000. We wanted to make it the highest possible for the costing so that we didn't come up short on what we costed out. But in all reality, that is not going to be the case with the amount of staff that we have. It was also proposed when we were discussing this yesterday of our primary department that is in need of this is our nursing department. So doing this for all of those in that department would be the ideal thing. And there's a couple of different SAP and operational issues with a couple of the things that Keith and Paul were discussing yesterday, and Paul might be able to elaborate on that a little bit more. But between either doing the neighbors as a whole or doing the nursing department, since the nursing department is the department that is in the dire need of both retention and recruitment, if that was the easier logistically, that would be the priority in our minds of bumping those positions up earlier to retain staff. At this rate, we have been losing staff between 5 to 10 a month, if not more. So if we wait 2 months longer, if we could do something now, maybe that would lessen that. So instead of having 20, if we say 10 a month for the next 2 months, maybe we could reduce that to 10 for the next 2 months, would be the idea of this, as well as having a recruitment effort to be able to post that wage sooner and hopefully attract new staff now instead of in January would be our goal with this. And as you can see, that $12,000, like I said, would be lower, but based on Jane's report this morning, we would be able to absorb that into this year's budget.
So if I may offer, in conclusion, look at these three options, and staff is endorsing 3 of them, recommending 3 of them to this committee. The extra $5 an hour when the CNA is working the shift alone is fairly straightforward and should be non-controversial. It's already budgeted. The vacation payout is consistent with what we've done elsewhere, and it's a good thing to give staff that really are working overtime, that they're not harmed in terms of loss of vacation because they're unable to take it because they're working so long, so many hours. And then this final one to basically give the 2022 raise early. We did talk about, would it bother staff if they get it early and they don't get it in January? And the feeling is that it's close enough to January that they'll understand it's not you're getting a raise in 21, but no raise in 22, that you're in fact getting 22's raise early. So 12,500 is, again, we think we'll be able to absorb it without necessarily going into the red for our annual net for the neighbors. And we endorse those 3. The one that we do not think we have the funding for is the shift differential. As much as we would want to do it to remain competitive or make ourselves more competitive with others, since they're able to do it, we simply don't see the revenues to do it. So our recommendation and what we're asking committee after its deliberations is to endorse those 3 items as approaches.
Okay, are there any questions? I've got one. Where are these CNAs going, Carmen? I mean, you hear every facility around is looking, where are they going?
They are, a lot of people are leaving healthcare.
Okay.
We've also had a lot of people go to agency staffing, which is another thing that is troublesome, is the agency staffing. They know they have the upper hand at this point. They can pay more because they know how desperate facilities are. And then facilities are paying them because we have to. Otherwise, we wouldn't have staff. And then staff are going to them because they know they can make more money. It's kind of a vicious cycle. It is something that associations are looking at. There's actually something, I was recently at a conference with the Leading Age, the state association, and that was one of their primary things that the advocacy kind of teams from the association was looking at was there are some states that have enacted rules on agency committee or agency organizations on how high they can cost people out. So that is something that our state has looked into. Based on the conversations, I didn't hear that it had gone well when the states had done that, and it didn't necessarily work, but at least it was an effort being made. But that is one thing we are seeing, people going to agency staffing.
Okay.
And
Okay.
the agency really has the upper hand because they know they can charge us more and they know that they can get staff by paying them more.
Well, I fully feel that we should endorse 1, 3, and 4. We've got to do something. How can we not? That's my feeling. What do you other folks feel? Anybody else have any other comments on it?
I completely agree with you. 1, 3, and 4 are obvious that we really need to do at least that.
Yeah, I also agree.
Sarah?
Well, shift differential has been talked about at the healthcare center for 30 years, and it's never happened. So I don't see anything wrong with it not happening now. You understand what I mean? I
Yeah.
mean, paying the shift differential is going to be a big hardship, then don't do it.
Yeah.
And the other ones, they all sound, as long as the staff doesn't get really angry about it, and some may, I think any one of them would be all right. I mean, they're not, it's, and to make it in just nursing services, that's fine too. At one time, I would have been opposed to that, but I'm not anymore because that's where you have the need. You don't have it in the other areas. You probably don't have, those kinds of problems in, say, dietary, or you don't have housekeeping anymore. So I would go along with one of the 3 is fine.
If I may add one other thing, the other primary reason for the nursing department is it is the one that is the farthest off from market. So comparing our current wages to what is going to be implemented, it's the furthest off. The other ones will have increases, but not to the same extent that the nursing department will.
So we're not, this is not listed as an action item
Right.
per se, but the feedback that we are hearing from you is essentially what we need. What I'm hearing is an endorsement of those 3 ideas. And I believe only one of them needs to go to Committee on Administration, and we have included that in the packet of materials for the Committee on Administration meeting next week.
I've got a couple questions, Mr. Chair.
Yes, sir. Go ahead.
First off, what is going to be the change in like the nursing if we changed it now instead of waiting until the first of the year? What are they getting now and what would they be getting on an average?
I do not have that in front of me, as when Heather and I looked at it, she took it back because it wasn't a final document. She said I couldn't have it. On average,
5%.
what was that?
I believe it's more than 5%.
Yeah. A 5% increase.
Yes.
All right. Well, I guess my thinking is, what's it costing us to have a house closed? And so I think we have to be competitive with our surrounding employers. And if it takes all of these, even the shift differential, I think we ought to be considering it if we want to stay in the business. Because if we if we can't keep employees and we can't keep enough, we're just going to keep going downhill. And the expenses there, a lot of the expenses there for the buildings and everything else, whether we have the beds full or not. And we keep hearing that there's seems to be lots of referrals. So if we had the staffing, we probably could fill the beds.
That
So
is correct. We are getting a lot of referrals, as well as we are not the only nursing home not accepting. It has been pretty consistent across the board. When I was at the conference a couple weeks ago, there are very, very few that are accepting, and those that I've heard of are accepting even with short staff. So we're not alone in it. And if we were able to staff, we would have our pick of referrals, I would truly believe.
Right, and that's what I'm getting at. So I think we need to really consider whether, if we want to stay in the business, I think we're going to have to spend the money and try to keep our employees. One thing I found out at the convention, WCA convention, is I was talking to a woman that was a surgical technician working for a company that she worked for a company. She didn't work for Gunderson, but she was working at Gunderson. She didn't tell me what she made per hour, but they were paying $84 an hour for her. And she said that she only goes to certain states, and she's in Wisconsin, so evidently Wisconsin is one of them, but most of her income goes towards housing and expenses like that. And in Wisconsin, $12,000 per year she paid income tax on. Well, that in itself is significant amount of money that we're battling. So you're battling more than just the difference in hourly pay. You're also battling what is coming out of their pay in taxes. I don't know, it was a very eye-opening to me to hear, what she was telling me. So anyway, as much as I hate to spend money that we don't need to, I'm fairly conservative, as you know. I think we really ought to consider all of these options, because in the long run, I think we're going to have to.
Other thoughts?
It's Mike here. I'd like to piggyback on Dave a little bit, but I don't know if I should open it up. But these are wonderful options. These are details. Carmen, Paula, Paul have really kept us up to date on what's going on. It seems like we really need a stable workforce and largely local. We've got support from the county. We've got great administration and management, great reputation, but it's spiraling downhill.
Mhm.
So this committee is really concerned with policy. So I'm thinking our policy has always been, okay, let's keep as many people in the bed as we can because it costs money and we need to pay for it. I think we've come to a time where we need to say, we need to keep only as many people in the beds, at least for now, that we can adequately staff. And I don't mean staff where people are being mandated. I don't mean where there's a whole bunch of overtime. It seems like as a committee, we could give Carmen the permission to say, okay, we only have staff to do 85 people. And this is staff that's working a normal workload. And if we ever did get down to something where the people were happy working, they're doing their job, we're having excellent outcomes, then you get the reputation, then some of the things that you've just mentioned here, the details, you can start building back up again, adding staff. But it seems like we need to give her the permission to go lower than 95, to go lower than 90, to go to where we have to go. And for the time being, the county support that. Because if we don't, I don't think we're going to have a neighbors in a while. We can't just keep trying these things alone. I think we need to do these things while maintaining a good staff, people that are happy to be there and are working in a normal job.
If I can just speak to that a little bit.
Go
So
ahead.
at this point, that has been what we have been kind of attempting to do with not admitting and then closing down Fireside. The issue at this point is we haven't opened up to admitting, and we won't admit until we do have that adequate staffing. But as people are passing away or discharging, we haven't been filling those beds. So that is what we are attempting to do at this point. We haven't gone to the plan of actually actively discharging people for that reason. That would take an actual relocation plan, which if that is what the committee would like us to do, we can look into that. But that is definitely a bigger state requirement of relocation plan for discharging people that would normally just be staying there. So we have not been admitting to any household, just out of clarification.
Yeah, and I understand that, Carmen, but I think you're still tied by us to keeping as many as you can, to maybe stretching your staff to keep as many people in the beds. And I don't want to see the staff stretched. That's just a spiral downhill. We're going to keep losing them. I don't think you would feel comfortable going down to 80 without the committee saying, well, we've got to do something. You know, you're still looking at it from the perspective of what we've asked you to do. And I'm saying go a little further. Give yourself the opportunity to say, okay, now my staff is working the way they should be working. We're not having to pay $5 to somebody because they're covering for two. And that's a policy idea. That's a policy idea. And that's what our committee does. And I'd like to have a little discussion and hear what the rest of you have to think about that, because you're going to lose money for a while at least. But in the long run, I think it gives us a better chance of maintaining a viable neighbors. So I'd like to hear what some of you think about that idea.
Well, my concern is, Mike, are you going to be able to keep the staff even if you got down to say 75, Carmen? Are you going to be able to keep them happy and not have the overtime and such as that? Or is it just going to keep going and going and going until you're going to have maybe 50 is all you can have for a census to keep a happy staff? When will it stop? This is my concern. And if we don't keep up being competitive with pay, I'm afraid it's just going to keep going. But that's just my thought. I don't know. Kelly?
Not directly to that point, but I think one of the things that we need to remember as we are having these discussions, we have been in a crisis with COVID for so long that's sort of become just part of our background. Any decision we make right now is a decision made under a crisis circumstances. And we have to remember that we're not going to get back to normal until COVID clears. And we have to, it's hard because people are bad at saying, at that long-term thinking and that long-term stress. But that's just something we always need to keep thinking about, is which of these are decisions that are important for the long-term health of the neighbors under the circumstances that we will hopefully getting back to soon, and which of them are we looking at mostly because we are in a crisis that we have become so used to that we don't even think about it.
It's a good point, Kelly. Dave?
Other than the options that we've seen, other than the $5 bonus per hour if a CNA has to work by themselves, all the rest of them are different, totally different issues than what Mike brought up. The rest of the issues are for trying to keep employees from trying to get employees. And we're not doing anything that our competitors are not doing already. So if we want to keep employees and try to get new employees, we have to be competitive. I totally agree with Mike that if we only have the staff for 75 people, then that's how many people we should have. I don't know that I'd want to go so far as make a policy that we would relocate somebody just because of low staffing, because it seems like we lose a few people every month, and without bringing in new people, I think we should be able to stay where our staffing can be able to do it without a lot of overtime and stuff. I'm hoping that anyway, unless Carmen would say different, because she knows and I don't. But I think it's two different issues that we're talking about here. And other than that $5 bonus if they have to work by themselves, the rest of it is, like I say, it's to try to get employees and keep employees. And if we ever want to keep going in business, keep going and keep the neighbors going, I think we're going to have to be competitive.
Yes, Paul.
Just food for thought for the committee as we're deliberating on this. We begin to touch on the real issue that we're facing, which is, as a publicly owned skilled nursing facility, we're in competition with privately owned facilities for a dwindling resource, and that is staffing, nursing staffing specifically. And the answer is money. If we were able to offer higher wages than the industry standard and what they're doing regionally, we would be in a much better position and more likely to attract RNs, LPNs, and CNAs. In fact, as an aside, we've talked before about the shortage of nurses in Wisconsin. We have put on our legislative agenda annually for at least 3 years an appeal to the state to expand its nursing programs because there's people on a waiting list. I had an opportunity to express that to Tommy Thompson this past week at Stout, that we have a crisis in nursing because we don't have enough. And why don't they expand the programs? And his answer was, we can't get the instructors. We can't expand the programs because we can't get the instructors, which sort of echoed what we have talked about in trying to get a CNA training program here at the neighbors. We can't attract the instructors. Well, the real problem with attracting the instructor is the exact same issue. It's money. If the state were to offer a premium pay, presumably those instructors would be inclined to be here. If you make it attractive enough, they would come. But from a macro perspective, we have to, I think the committee wants to bear in mind, we can throw more money at this trying to sustain it. At some point, we run out of money to throw. And we may, the ideas that we have, including the shift differential, may not solve our staffing problems because of simply inadequate numbers of qualified staff and because we can't keep up with private industry when it comes to those salaries and benefits. We've tried before to attract them or sell them on, hey, as a county employee, you get retirement benefits. You don't get those in private. You don't get WRS, the defined benefit plan. These young people don't care. They look at that bottom line. They look at that paycheck. So we do need to decide at what point is there a point at which the neighbors is unsustainable as a county venture? Do we reach that point? And if we don't, how much do we end up sacrificing potentially in other areas in order to sustain it? We could say that we're going to use the money in the general fund balance, reduce it by $350,000 to pay the shift differential, $3 an hour. Hope that that attracts more people to work, not knowing it, but hoping that it does. And that could have the consequence of dropping us below the threshold goal of 30% of our operating, which harms our credit rating and our ability, when we do need to borrow, to do so in the future. There's consequences. And I'm not saying we shouldn't make that decision. That's up to this committee and ultimately the county board. But we need to understand the priority that we've placed in that case, in that scenario, on sustaining the neighbors at the consequence of negative impacts for other program services and the county's fiscal position.
Mr. Chair.
I'm sorry.
Oh, I'm sorry, Paul. I thought you were finished.
No, please
Go ahead, Paul. I thought you were.
Go ahead, Supervisor Kinnear.
Yeah, excuse me. I didn't mean to interrupt. I just thought you'd concluded, but
That was enough.
no, Chairman Bartlett, as usual, comments clarified it for me and what I'm really trying to say. And Mr. Miller kind of threw in some details there too. The suggestions that were presented to us today are short-term. Those are things that I totally agree with. But looking long-term, we have to improve the workplace situation. And that's where I'm saying, don't take any more people until we can actually staff them. That's what you're doing. But I'm sure you're still in the back of your mind, Carmen, thinking, oh, we've got to somehow work. You've got to work till 11 at night doing CNA work yourself, Carmen, or those kinds of things. But we need to get down to where the staff wants to be there and people want to work there from outside. It isn't money oftentimes. It's the people you work with and where you're working and what the job surroundings are like. So I'm saying long-term, if we want to at least get on the road back, is we need to reduce as slowly as attrition, reduce the number of residents until we can staff them in a reasonable manner. And I think when that happens, word gets around, we get more people, you can start raising residents again. But it's a long-term thing. And in the short term, we need to do all these other things. But so thanks, Dave, as usual, for clarifying what I'm trying to say. And Paul, you filled in the details. That's it.
Only other, if I may, Mr. Chair, the only other thing I would add to what Supervisor Kinnear said is there is a cost, and Chairman Bartlett mentioned this in his comments, there is a cost to empty beds. We have to pay that bed tax regardless of whether or not it's occupied. So there becomes a point below which when our census is too low and the cost of the empty beds exceeds the value of the ones that are occupied, presumably. And even if we don't reach that point, there does come a point where the cost of those empty beds becomes a significant factor in evaluating the continued viability of the operation.
Right.
So keep that in mind as well.
I agree with that.
Short-term gain, short-term loss, long-term gain, we hope. But yeah, reevaluate all the time. Thank you. I am finally done, Chairman Johnson.
Okay, how do you want to proceed then? We want to support 1, 2, 3, and 4, or 1, or we've got to give an answer here. Personally, I think 1, 3, and 4. I do not support number 2, but that's just my thought.
I think at a minimum, we need to do 1, 3, and 4. I would love to do 2, but I don't think that's financially viable for us right at this moment. I really wish that I had a different answer than that, but I don't.
Sarah?
Well, I agree. The shift differential would be nice, but that's pretty costly. And it can also, I hate to say this, but it can also create some problems between the staff when it only pertains to one group. And I hate to see that happen also. So I think the ones you're talking about are the ones we need to go with for now.
Is that okay, Mike? Dave, you go with us?
Yeah, I'll go with it. I'm just throwing out my opinion.
Yeah, no, that's why we're all here. Yeah.
If the comparables say that we're way under, I think that makes a big difference to the night, especially for the night staff. How many, you're closing Fireside, is there another house closed too, or is that gonna be the only one?
Arrowhead remains closed. So Arrowhead and
Okay.
Fireside are
So
two.
it'll be the second one being closed.
Fireside will be the second. Arrowhead has been closed since, I believe it was November of last year, so about a
That's
year.
what I thought. I just wanted to make sure that I was thinking right. Thank you.
Okay, well, we'll move on with the general feeling that we support 1, 3, and 4. So take it from there, Carmen.
All right. Also under this agenda item, just because since it's a newer thing, it wasn't on this report and we haven't costed it out yet, but there has been another idea that was posed, but I'm waiting to hear from therapy. As our Medicare census has decreased, our therapists have less workload. And that is something that they are trained and able to do CNA work as a physical therapist or an occupational therapist are able to do some, if not all of what CNAs do. And then speech therapists are able to feed residents as well. So that is something that we're exploring with our therapy contract of how to work out, having them help with those things outside of what's considered their productive time, which is actually therapy charged minutes. So I did meet with our regional director from our therapy company on Monday about this, and she was getting numbers and how that would work with adjusting our contract with them as well. This would also be beneficial to keep our therapists if they don't have hours here, they might be transferred to other locations or different places where they could get hours as therapists. And we have a very good therapy team. So an added bonus of not only filling some of those shifts or sorry, my lights keep turning off. Or helping out with certain busy times of the day. It would also incentivize our therapy staff that have been at the Neighbors for a long time to stay at the Neighbors as well. So that is something we're exploring, but I don't have numbers for you yet because I have not gotten any formal documentation or anything from the therapy company.
I also wanted to add, just as a conclusion on this point too, the one item that will go to the Committee on Administration is the $5 bonus, if you will, or additional pay when a CNA is working a shift alone. That will go under an amendment to our temporary COVID-19 policies. So that one will be the one going in front of the Committee on Administration.
Okay.
All right, before we move on from that to the actual employment report, does anyone have any other questions for me on the staffing stuff? Okay, so then I'll have Chris do the employment activity report.
Oh, so I'm just going to run through the numbers of the people that were hired and left, that type of thing for this one. So number of interviews scheduled, we scheduled 9, we held 8. 8 positions were offered, 8 positions were accepted. We had 3 resignations for September, or that fell in September. One of them, they were all part-time CNAs. One went to a nursing agency for a higher wage. One walked out for no reason. The other one, there was school commitments and staffing issues. So if you go down to open positions, it'll just list what is open for the month of September. So we had 1 full-time RN in September. We had 5 LPNs in September, 8 CNAs in September. For open positions, we did have 12 part-time homemaker positions open. And that is a jump because that was because of the approval for the PM homemakers, which we are hiring for. If you go down, kind of look at the leaves of absence, we do have a number of them that started kind of tail end of August, beginning of September for educational leaves. So that they're listed there. Work comp hours, we didn't have any lost time for September. And then the number of shifts missed in September due to COVID-19, if they called in with symptoms or that type of thing, was 47, or roughly 392 hours missed. For October to date, I have 11 terms and 7 new hires for October. So October's report won't look as because everything, they put their notice in end of September, it hit in October. So is how I count the term date is when the month it actually happens in. So
I'll just add a little bit to the end of the COVID. We have seen, and this was probably mentioned last month as well, a fairly significant uptick in COVID related call-ins again. Part of that being close contacts, part of that being symptoms. And we also do think that there's been more and more call-ins just from exhaustion and everything else. And anytime anyone is sick with anything, they're automatically off for 72 hours, pending COVID tests, and 72-hour symptom free. So that does add up to extra shifts too, not just the shift that they're calling in for. So that is why that is so high.
Yeah.
Any other questions on this? On that note, we will move on to the resident referral report. As you can see, this looks the same as last month with the referrals. We have seen a lot of referrals. As I mentioned earlier, we are not the only building not accepting. The hospitals at this point are having a fairly hard time placing residents. We have heard that from our hospital systems. They are full. They are full with multiple reasons. They're full due to the pandemic, having more COVID cases, as well as not having a place to discharge people to. It's hard for us definitely to be short on staff and to say no for admissions, but it also does back up the whole healthcare system as well. So the effect that the staffing shortage has had is it's widespread on multiple parts of the healthcare system. And it just continues to get harder as more and more facilities are not accepting, for good reason, obviously, but it is backing up the hospital systems as well. So we've actually seen an increase in referrals from other facilities or other nursing home or healthcare centers like hospitals and clinics and such, as their local or nursing homes aren't accepting either. So similar to at the beginning of the pandemic, when people were not able to accept due to positive cases, and we saw more and more referrals, we're seeing that due to not accepting due to staffing now. So we did have 75 referrals. We had 1 admission. On the referral reports, we do readmit residents. So if they went to the hospital for a certain illness, they would, if they're out of the building and they're not a bed hold, we do have them come back in. So that is that 1 admission was a readmission from someone who went to the hospital. And there'll be 1 or 2 on the October report as well, of people who went out to the hospital and then came back to us as a readmit. So we had 74 not admitted. As Tracy did right on here, but as I talked about last month, even with the 75 referrals, we probably wouldn't have admitted all of them. Historically, we've admitted about 50% due to other reasons. So granted, 74 people were not admitted to us, but it would have probably been around the 40 number of admissions if we had the staffing and the open beds. At the end of the month, we had 102 residents. We had 0 residents transfer to another facility. We had 5 deaths and we had 1 discharge home. Our discharges are also smaller due to not having short-term rehab census. Any questions on the referral report? Okay. So Scott is on vacation, so I have Josh Delaney here with us today for the environmental and facilities report.
Welcome.
Thank you. So far, we're kind of shifting into winter mode for the grounds and facilities. We've more or less kind of put our mowers away, getting our snowplow equipment ready for snow, which I'm sure will be here probably end of the month. It's really not a whole lot to report. Nothing major has happened, I guess, with facilities and grounds here. But so, any questions from you guys?
I will
I hope
add,
you're talking the end of the month, you're talking November, not October.
Well, I wish it was November, but I think October is probably going to be it.
I will also add for Josh, as I know we typically, since our meeting is later in the month, we've gone through a lot of October already, but we have been working on our emergency preparedness annual training, and we actually did our evacuation drill yesterday. So if you drove by the neighbors and you saw a lot of police officers or firemen here, that was on purpose for our evacuation drill. So we do that every year. It's a federal requirement to do evacuation and emergency preparedness for all skilled nursing homes. So we are in the middle of working on that for a year. So.
Thank you, Carmen.
All right. Next, we'll move on to the COVID-19 update. As I did mention, we have had more cases of COVID-19 in staff and more people being out due to exposures as well as symptoms. We have had outbreaks of staff across campus here and there, one-off situations. We have not had any outbreaks that were connected to each other, so no staff to staff. And we have not had any resident cases since last November when we had discussed that almost a year ago now. So we are still doing okay in that matter. As far as vaccinations go, as you may be aware, last night Moderna was approved for the booster shot. We have been in contact with our pharmacy contracts, with Walgreens, who did our last shots, to get in booster clinics for our residents and staff here. The majority of our residents and staff received the Moderna vaccine, as that was the vaccine that we offered here on campus. So we've been in contact, but we are waiting for the approval to be able to administer boosters for Moderna. So we will hopefully be doing that shortly. We were hoping to do it at the same time as our flu vaccines, to do it all in one swoop. But we did start our flu vaccines in the first week of October. So we have done flu shots and TB skin tests for the year. And we'll have a clinic for COVID boosters as well. The other vaccine topic is the vaccine mandate. That has been on the front of everybody's minds lately. It was public knowledge that Mayo has mandated the vaccine quite a while ago, and it is now being fairly strictly enforced. So we have actually had nurses reach out to us from Mayo. We have not yet mandated the vaccine. We are waiting for the federal mandation to come out, which we anticipate any day now. As of last week, it was in the final approval process, which, based on the experts that were discussing it, said takes about a week normally. So we're anticipating it shortly. If it goes with everything else that CMS has done with COVID, it'll come out on Friday afternoon. So that's kind of been their MO for all of COVID policy changes, was Friday afternoons. So I am anticipating seeing something about it tomorrow or next Friday, as that has kind of been their standard. So at that point, we will evaluate what that means for us and what the exceptions are and everything like that. That is also something on the front of our minds of staff. We have over 70% of our staff vaccinated. That ebbs and flows with turnover, of course. but we are hoping to see more of our staff vaccinated before that mandate. We have pretty much a couple every week coming in with new vaccines, which is great. But we're still have quite a few that are unvaccinated that could affect our staffing at the time of the mandate as well. And we'll keep everybody apprised of what that means at that time. Anyone have any other COVID questions or anything for me?
I have a question about your staff and the mandate. Have you had anyone basically saying that if you mandate the vaccine, they'll leave or
Yeah.
not?
Yes, we have.
Okay.
We have had people say if we mandate, we'll leave. We have had people from places where they have already mandated contact us to see if we have, because they want to leave their current employment, which obviously we want more staff, but at the same time, if we get them in here, train them, and then we find out next week that the feds are going to mandate it for us, we don't know. But we have had a few people say they will leave if they're mandated to get vaccinated. At that point, that is why we're so pleased that the federal mandation did change from being just skilled nursing to all Medicare and Medicaid accepting facilities of healthcare facilities, so hospitals, clinics, all of that. That was a big change for us and a positive one, as it leaves less places for people to then go to if they don't want to be vaccinated. So at this point, we're just kind of waiting to hear what that is.
I wanted to share, Mr. Chairman, just information for the committee. We even have had some employees who have said if they're required to be tested weekly, they will quit. So it's not just the vaccine that they're opposed to.
Thanks. Kelly?
Yeah, if I might add to that, we're starting to get the data on the actual numbers of people quitting in mandated fields and area. And the threats to quit have been much, much lower than the actual numbers. So it is somewhat hopeful that in general, with the places that have gone with a mandate, the loss of retention has been about 0.5%. Just data that will make that seem maybe a little bit more hopeful.
Yeah.
Right.
Yeah, there has been definitely, when I was at the conference a couple weeks ago, there has been quite a few facilities that have mandated. I do know that a lot of places in larger cities have mandated. Public opinion is also part of that as well. It does worry me a little bit that here, even our public county vaccination rate is quite significantly lower than some other places, which is what worries me here comparatively to other places. But I have heard the same, that in certain places that have mandated, the anticipated turnover was much worse than what the actual was due to mandates. So it is hopeful.
Yeah. Okay. Anything else from anyone today?
I've got a question.
comment.
Dave, go ahead.
What do we get for a Medicaid bed? What are they paying now?
With the new rates?
Yeah,
So it depends on what facility you're in. I can actually pull up our projected actual rates. So I don't
just an average or whatever, one of them.
We'll pull up the actions. So we are projecting to be at, for the new rates are going to be at 280, 282, and 283 is the estimated that Leading Age gave us for the three. So which is about 10% increase. But that is with the new system that can change. So that's the projected for that July to now, basically, which October is when they're supposed to come out with the new rates, with the changes and the vast increase in all of the different processes that the Medicaid system is currently going through. They have been delayed. We should have known officially in October, but we're hoping to know by November, but that is the projected.
Does that answer your question, Dave?
Yes, it does. And that I want you all to think about that. We've got 30 beds that are open.
Yep.
If we had the staff to fill them, we evidently have the referrals to fill them. The only way we're going to get the staff is to pay more than our competitors. I've been in business. That's the way it was when mechanics were scarce. You can do all sorts of things to keep them, benefits and whatever, but to get them in the door is how much you're going to pay per hour when they come. And then all the other stuff to keep them, whether it's a great place to work, great people, and you treat them fair, and you give them good benefits, all that stuff is to keep somebody there. But to get the employee in the door, to come and work for you, to start with, it takes, what are you going to pay them? Because that's what they're looking at of the competitors. And I'm just throwing that out there, that 280 times 30 times 365 would pay for a lot of compensation for employees. We want to stay in business. It's either that or, like Mr. Miller said, sooner or later, the expenses are going to be enough that we're going to have to say, we have to get out of the business. That's what I'm afraid of, and I'm trying to stop that. I'm just throwing that out there for you guys to think about a little bit more. I'm not trying to get you to change your mind, but to think about this for the future. Because right now we have the opportunity to fill the beds if we had the people. Thank you.
Duly noted, Dave. Mike, you had something?
No, I just wanted to say staff, they've been doing a great job. I can't say enough about what everybody's been doing, Carmen and the rest.
Absolutely, no doubt. I agree with you 100%.
Thank you, and we will pass that along to all the staff as well.
Anything else from anyone? And hearing none, this is a good meeting. I'll hope to see you at the next meeting. I'll adjourn the meeting. Everyone have a good day.
We do.
See you all next time.